So thanks for joining us today for our Tobacco Endgame Centre of Research Excellence webinar. Before we start, I'd like to acknowledge that I'm on the unceded lands of the Jagera and Turrbal people. I pay my respect to their ancestors and descendants who continue cultural and spiritual connection to country. And I acknowledge the valuable contributions of Australia's First Peoples to Australian and global society, and acknowledge any Aboriginal and Torres Strait Islander colleagues joining us online today. It is my great pleasure to introduce Professor Billie Bonevski to deliver our webinar today. Professor Bonevski is the lead of public health at Flinders University and also our Centre's Deputy Director, and she's also one of Australia's leading researchers in smoking cessation research. Her research targets population groups at very high risk of tobacco-related disease, and her research is delivered through community and real-world settings such as mental health and drug and alcohol services, Aboriginal health services, and housing and financial aid services. Today she'll discuss the development of a research program that has provided an evidence base for the Tackling Tobacco program, which aims to build the capacity of community-based organisations to support their clients to stop or reduce smoking. While Billie is delivering her presentation, please feel free to enter any questions that you have about the research into the Q&A function that you'll find at the bottom of the screen. And we'll try to get to these at the end of the talk. So now I'd like to hand over to Billie and thank her very much for making the time today to present to us.
Oh, thanks, Coral. I'm absolutely delighted to be here talking about one of my favourite projects and research. And I also would like to acknowledge that I am on the unceded lands of the Kaurna people. Flinders University has campuses that run all the way up and down the central corridor of Australia, from the very top of the top end and Yolngu country in Nullarbor, right down to the Fleurieu Peninsula and Garangeri and Ramangeri lands and Iona Elders past, present and emerging, and extend my respect to Aboriginal Torres Strait Islander colleagues who might be on this webinar today also. And I'll just make a funding disclosure, always really important in tobacco-related research. I've received funding from lots of places, but importantly, never from tobacco or vaping companies. And just a really quick note on the language that I'll use. Smoking is a stigmatised behaviour, as unfortunately is mental health and drug and alcohol use. And so my preference is to use people first language and refer to people who smoke rather than smokers, people with a mental health condition or people in various types of treatment. So I'll attempt to do that throughout. And I just want to acknowledge the magnificent team. No research, certainly not the sort of research that we do, is a solo endeavour. It is by working in great teams, and this particular is a great team. Most of them based still in Newcastle and still working with me on a lot of this research, and I'm very grateful for their collegiality and collaboration and just being clever clogs. So today, as Coral indicated, I'll talk about the Tackling Tobacco program and the research behind it. So I'll give a little bit of an overview of what the Tackling Tobacco program is, if you haven't heard about it before, and a little bit of a background as to how we got to developing a Tackling Tobacco program. I'll describe some of the research that went behind Tackling Tobacco, and then describe some of the ongoing work that is happening in translating that research into policy and practice delivery or program delivery. So first up, Tackling Tobacco is an initiative of the Cancer Council New South Wales, and I think it was about 2006 or 2007 that they started to really make a commitment to addressing high smoking rates. They noticed high smoking rates amongst certain population groups in New South Wales. And, you know, with that comes consequences, particularly for cancer development. So the Cancer Council New South Wales made a program delivery commitment to reduce smoking amongst the most disadvantaged population groups in New South Wales. And they did that through partnerships with the NGO sector and particularly community social service sector. And they were really clever about it. Of course, smoking has health impacts, but they reframed smoking as a social justice issue because of the high rates of smoking amongst population groups that did experience various forms of disadvantage. And they worked with the community social service sector to build the capacity of those organisations to support their clients to quit smoking. And so I came into this when the idea of tackling tobacco had already been formed, and there was a need for research or evidence to drive the way forward. So it was about 2008, and I'd just come back from maternity leave that year. So I was really, really fortunate and privileged to walk straight into this program of work. And we did a lot of formative research, qualitative research, talking to people who smoke, people with mental illness, people getting treatment for other drug and alcohol use. We started to develop interventions and programs based on that formative research and to pilot those programs in services in the community. And then we ran some randomised control trials that were powered to determine the effectiveness of the programs on smoking rates. And now we're at, you know, translation and implementation phase. So I'll talk a little bit about that research. Firstly, just and also it was a partnership program. So many community social service organisations participated and were involved in tackling tobacco. There was a lot of good faith between the Cancer Council and community social services. A lot of these organisations understood that smoking contributed to their clients' disadvantage and impacted their ability to have a good quality of life. So, you know, really grateful to, these are some of them, but there were many others as well. So a little bit of background, and I'm sure I'm preaching to the converted, but as many people would know, that we have a social gradient in smoking rates in Australia, and it existed for a little while. So the timeline on this graph goes back to 2001, and the line at the top shows the highest smoking rates, which are amongst the people with the lowest socioeconomic status. This is using ABS data, or Australian Bureau of Statistics data. And the light blue line down the very bottom is represents the highest socioeconomic status groups. And you can see that they have the lowest smoking rates. And then there's that gradient that goes between the 5 socioeconomic status levels. The purple line in the middle is the average Australian smoking rate, about 12% around 2019, 2020. But smoking rates are a lot higher amongst certain population groups. And in Australia, the highest rates are seen amongst people who have harmful use of other drugs. And you can see there that it's around 84%. So almost everybody smokes tobacco. Really high amongst people who use alcohol as well, hepatitis C, and then there's some mental health conditions. And it's important to just note that there's overlap people with mental health conditions and people with other substance use. There's a good deal of overlap between those two, but also then with tobacco smoking coming, over that as well. And the consequences are significant. It means that there's disproportionate impact of smoking-related disease on people with various forms of mental health conditions, including substance use. And it's so bad that the National Mental Health Commission referred to the impact of tobacco smoking on the physical health of people with mental health conditions as a national disgrace, and it truly is. Tobacco-caused diseases are the leading causes of mortality and morbidity amongst people with mental health conditions in Australia. 2 times the rate of cancer, 5 times the rate of cardiovascular disease, and 6 times the rate of asthma. And there's this big life expectancy gap. It's all unacceptable, and good reason to see if there's some way that we can support people to quit the smoking. And there's other impacts of smoking on their mental health as well, not just their physical health, but there's studies reporting that smoking is associated with more psychiatric symptoms amongst these population groups, increased hospitalizations. The nicotine has an impact on the medications that they might be on, and the ever-increasing cost of cigarettes is leading to significant financial stress and smoking-related financial stress. Mohammed Shahpush did a lot of work around that. So helping people quit smoking, though, improves their physical health, improves their quality of life, mental health, alcohol use. And there's even a study, I think, that Robert West was involved in years ago that showed that quitting smoking is related to increased rates of subjective happiness ratings as well. So there's many reasons to address smoking amongst these population groups. And they want to quit. So there's survey data. We've done a number of quantitative surveys looking at the number and recency of quit attempts that people in mental health or drug and alcohol services or even community-based social services have made, and they've made lots of quit attempts, and often they're unassisted quit attempts. And they plan to make more quit attempts fairly soon, in the next 6 months or so, and they have good motivation to stop smoking. We've talked to so many people about their smoking and about quitting. They really would like someone to help them with their smoking, and someone who genuinely cares for them and will support them in quitting smoking. So why is it so difficult then, if they're quite interested and motivated to quit smoking? And there's a range of studies that have made a number of connections that are helping us draw this picture of what might be going on. And one of the key things is heavy nicotine dependence and high numbers of cigarettes smoked per day. Often this is because they started smoking at a much younger age, and so by the time we get to them, they're smoking a lot. They're heavily nicotine dependent, and they experience severe withdrawal symptoms when they try to quit. Smoking alleviates some of their mental health symptoms. And then there's the whole social and environmental context of smoking as well, where a lot of the people that they know, that they might live with and socialise with, also smoke. When we talk to them about self-efficacy, whether they believe that they can quit, they want to quit, but self-efficacy tends to be quite low. And there is some research showing that financial stress that they're experiencing due to smoking can undermine their quit attempts, and they relapse back to smoking. But of particular note is this last point, and research that has found that people from these population groups that are at higher risk of smoking and higher risk of the health impacts of smoking tend to receive less health provider advice to quit smoking, and there's a variety of reasons for that. It's inexcusable though, because providing smoking cessation support is clinically recommended. So in Australia, from primary care, like the RACGP guidelines, as well as each health service, have their clinical guidelines that provide step-by-step guidance on who should receive smoking cessation support and how to receive it. And it's based on the evidence. There's really good evidence, and there's multiple Cochrane reviews and systematic reviews of the evidence that shows that even brief advice can increase quit rates from this general population unassisted cessation rate, and then providing a bit more involved behavioural counselling increases it again. And we know that combining pharmacotherapies with behavioural support provides people with the best chance of long-term quit. And these strategies and smoking cessation interventions have been tested in trials with people with either alcohol and other drug use or mental illness. And within these trial conditions, there's a good body of evidence now that shows that if these people who smoke are provided with evidence-based therapies, that it is effective, that they do achieve smoking cessation. However, in real world settings, we're finding that people are not being provided with even fairly basic, like brief advice in health services, in some health services. And this is the result of a survey of staff across a number of drug and alcohol services, and staff self-reported to routinely provide brief advice to their clients who smoke only, in 19% of cases, and with NRT only about 11% reported that they provide this routinely as part of routine care, and so on. So as you can see, the provision of the evidence-based smoking cessation support is one of the challenges. And as I said earlier, there's a range of reasons why they're not receiving smoking cessation support within these treatment services. There's historical, there's this culture in mental health and drug and alcohol treatment services where smoking was an accepted part of the service provision. There were cases where there were high rates of smoking amongst staff in the services. This was often done to build relationships with clients, and staff also reported a lack of confidence and had not received training in how to provide smoking cessation support. Some of the services that that are in mental health and drug and alcohol treatment are inpatient settings, and that makes them residential settings. And, you know, staff would report that within someone's home, you know, where they're living, that smoking is a right, that, you know, we can't interfere with that. There are genuine fears that their mental health or their other treatment outcomes may worsen, and there's fear of aggression as well, because there are some reports of staff being attacked and by clients who have tried to quit. So this was why the Tackling Tobacco program focused on trying to build the capacity of these mental health and drug and alcohol treatment settings to provide, to facilitate the provision of smoking cessation support as part of routine care in those settings. So we employed what's referred to as an organisational change approach. And what organisational change within the context of tobacco control is a set of policy and practice changes that are designed to integrate the identification of people who smoke and then the subsequent offering of support to quit into routine delivery. And we designed these interventions based on a couple of existing models from the US. So Michael Fiore's systems change model that has been used in health services in the US, and Zadonis's addressing tobacco through organisational change, or ATOC model. So this was really useful in that it provided a good framework for us to work with, but those models hadn't necessarily been adapted to the Australian context and hadn't really been evaluated robustly through randomised controlled trials, particularly in mental health and drug and alcohol treatment settings. Organisational change is a multi-component intervention with all sorts of strategies that look at practice, culture and systems change within organisations. So I'll run through one example of one of the trials that we conducted, called the Tackling Nicotine Together trial. Again, this was conducted in partnership with the Cancer Council New South Wales, of course, as well as drug and alcohol services in Australia. And some of you might recognise that building in that photo is the Needle Exchange in King's Cross. So the TNT project was run in 32 drug and alcohol treatment services across Queensland, New South Wales, the ACT, and one site here in South Australia, in Adelaide. And it was a cluster randomised control trial, and I apologise for the busyness of this slide, but it's a basic, you know, a consort flow diagram there showing that half of the drug and alcohol sites received the organisational change intervention, the Tackling Tobacco organisational change intervention, and half served as a control group where it was usual care provision, and we just collected data from those sites. We collected data at a 6-week follow-up and then a 6-month follow-up, and we collected both service data and data from clients who participated in the trial. And there is a protocol paper that describes all the details of the methods of this trial. And the organisational change intervention included 7 components. And, you know, as I mentioned, these components are drawn mainly from the US-based Fiore model and ATOC models. And the first one was about engaging organisational support, and that was very much a top-down approach where, and the Cancer Council New South Wales played a big role in this, in CEO, talking to CEO to ensure that the delivery of this intervention was a organisational leadership commitment. The second component was for us to, at that ground level now, to identify champions for the TNT project. And this was really easy to do because we found in most drug and alcohol treatment services that there was someone who was affected by either their own smoking, or they had a family member who was affected by tobacco-related disease, and were passionate about addressing smoking in their workplace. It was also important that that champion was not only passionate about addressing or tackling tobacco, but that they were fairly influential within the organisation. So that champion was the link between us as a research team and the service setting. And the champion was also the person that kept the project on the agenda, kept it in service-based newsletter and in team meetings, and provided updates at that ground level in each service. And we had fabulous champions in our intervention group. We provided staff training, so the fabulous Tracy Greenberg did a lot of that, and it was bespoke training. It was tackling tobacco specific from the Cancer Council, and it was a full day workshop, face-to-face with staff in the treatment services, and then a couple of months later, roughly, they would get a half-day booster session just to identify any issues and work through any issues that might have come up and how to address them. We supplied lots of resources. They might have been posters for the walls, they might have been quit plans. The resources provided mainly from the Cancer Council. We also, this was an NHMRC funded trial, so we were able to provide free nicotine replacement therapy to each service that they could then hand out to their clients. And this was really important. This was an enabling feature, the fact that people didn't have to go to get a prescription and, you know, try nicotine replacement therapy in a way that cost them money. It addressed financial barriers to using nicotine replacement therapy, and it also empowered staff in the clinics to have that conversation with their clients. Some clients didn't want to use NRT, which is fine, but at least there was NRT there that could be offered, and there was also the opportunity for trial and error of different types of NRT. So one type, you know, lozenges may not work for someone, but patches and inhalators might. You know, it was good. We worked with sites, and most sites had electronic record systems, but we worked with sites to develop fields that recorded clients' smoking status. And some sites took it further to include fields on what quit support that client had been offered. So this meant that every time the client came into the service, there was a record of what they'd been offered, and it didn't matter which staff member was seeing them. They could just pick up on where things were at their last visit. And we helped sites develop policies. So Government-run health services, of course, are smoke-free sites, but quite a number of our participating services were NGOs, and so they may not have been smoke-free sites. They may have had a room or a location in the service where it was a designated smoking area and people could smoke. So we use templates from the Cancer Council. As you can see there's the policy toolkit on helping sites develop those policies. If they were government-run health services and they already had smoke-free site policies, then we worked with them on adherence strategies, because even if a site was smoke-free, it didn't necessarily mean that all staff or all clients adhered by that policy, and so we worked through that. It was very tailored component of the intervention. So these are the results of the trial, and all the details of the trial are published in this article. And as you can see there in the plot, we saw a range of improvements compared to the control, where we saw improvements in the receipt and use of NRT. We saw improvements in self-reported, this was 7-day point prevalence, abstinence, and increases in the number of quit attempts people were making. Our primary outcome was not significant. So our primary outcome measure was 7-day point prevalence at 6 weeks, and although it's leaning towards improved outcomes, it hadn't at that stage reached significance. So you know, this has caused us to think about what primary outcomes we use in studies like this, that when we're doing big organisational change interventions, it might take a little while to see that translation of, you know, better provision of support and NRT and so on within an organisation to then translate into significantly higher smoking cessation rates. So we were we thought, you know, these results were positive because within drug and alcohol treatment services, quit rates are usually 0. So getting any sort of improvement in quit rates, getting improvement in the delivery of smoking cessation care, which is the main aim of an organisational change intervention, is positive. They're positive outcomes. So based on that, we then went on to, again, together with the Cancer Council New South Wales, who are truly leaders in this space, in developing another intervention, organisational change intervention for tackling tobacco in mental health service sites, and this is funded through New South Wales Health and the Cancer Council New South Wales. And again, it's a cluster randomised control trial, rolling out the trial in 26 mental health, community-based mental health services in New South Wales. And again, you can see the consort diagram there in terms of sites were either randomised to receive the intervention, or in this case, the control group was a type of really minimum intervention where where the sites only received a really minimum level of support around tackling tobacco from the Cancer Council, but much more intensive support in the control group. And that study is is being written up now. So we've completed the trial, and the lead, Laura Twyman, is writing that study up. So watch this space. I'm excited about those results coming out soon. Okay, so what was really important for the Cancer Council New South Wales is that all this research, and this is over 10 years of research by now. So, you know, the timeline probably hasn't been expressed very well in this, you know, sort of 20-minute presentation, but all the research indicated that there was a need for something to be done, that that people who smoke with mental health conditions or drug and alcohol use really wanted support, that if we worked with community-based social services, that they would increase the level of support that they provided their clients, and then that will, you know, that alone is a great outcome, but that will translate into reductions in smoking in the community. So tackling tobacco has become a really important program for the Cancer Council New South Wales, and this page here is just a snapshot of the website. So anybody can go online and look up Tackling Tobacco Cancer Council, and you'll find loads and loads of information. The Cancer Council continues to provide tackling tobacco support and grants to community-based services, not only mental health services and drug and alcohol services, but a range of different types of community social services. They provide policies and tools and resources and advice from tackling tobacco workers at the Cancer Council, and they tailor the program to each individual service, and they provide training as well, and they have had NRT grants that they offer every now and then to services as well. So this again is a snapshot from their website. The program is being rolled out to hundreds of community-based social services in New South Wales, and it's providing smoking cessation support to people who had previously not received any smoking cessation support. So that's really, really important. So if tackling tobacco didn't exist, then these clients, these people going to community social services would not be getting assistance to quit. We have a national implementation committee now, and there are cancer councils around Australia who are licensing the program and implementing it in their states. The National Implementation Committee has representatives of every cancer council in every state and territory in Australia, and me. I try to get to meetings when I can. And I'm really proud that this year's South Australia Cancer Council has licensed the Tackling Tobacco program, and it'll be rolled out here in South Australia as well. It has a profound impact on people's lives, and a lot of these things are often not captured. But they are in the case of tackling tobacco, because you can go to the website. For example, this is Cancer Council New South Wales, and they have case studies. They're case studies from different organisations, and it describes, you know, what impact this program has had at that organisation level, but also at, you know, the client level for those organisations. So Trent's story is one that I really like. You know, he says, I do consider myself an ex-smoker now. I still use a little bit of NRT, but, you know, only when I'm around that triggering environment, or I'm super stressed, I feel accomplished, that I've beaten that cycle of addiction. And, you know, this is why we do what we do. This is, for me, this is real impact. The Tackling Tobacco model of partnering with community social services was recommended in what is still the current national tobacco strategy. And I think there'll be the new one coming out soon, but also New South Wales tobacco strategy. It's in the position papers for tobacco-related disparities and mental health services. And this program of research was awarded the Thoracic Society Australia New Zealand President's Prize, which is awarded for you know, doing great things in tobacco control in Australia and New Zealand. So, and I think it's well deserved for the TNT trial. Okay, thank you.
Okay.
Yeah.
Thanks, Billie. That was a great presentation, a really good overview of that program and how it's developed and continued on. We don't have, if anyone has any questions from the audience, please feel free to put them in the chat. We don't have any, but I guess I've got some questions that I can throw to you. Just one of the trials that, like pilot trials that we were involved in, which had people who had multiple issues like, you know, low income, chronic health conditions and so on. Some of those people who quit reported in sort of qualitative interviews afterwards, you know, sort of other benefits of quitting that I think you've sort of captured here. You know, financial benefits came up big, and also like self-esteem and so on. What do you think about, like, you know, that we should be capturing sort of these wider benefits in our trials that we're running for?
Yeah, Coral, I think that's really important. And I think that does often get lost, because we had the same experience with, you know, people saying, I could never afford to take my kids to the movies and now I can. And that may not sound like a big deal, but for someone who's really struggling financially, it is a big deal to have that financial bonus, but it also means closer relationships, you know, being developed with kids, and role modeling, you know, a certain type of behavior. So I think that having qualitative work around those trials, whether it's to guide the development of the research, or afterwards, as you say, to really capture the impact of any intervention or program that you might have delivered, is really important. And I don't think we do it enough. And that's probably because of funding constraints. And it's probably something that we really need to include in funding applications, is that follow-up to capture meaningful impact of research on people's lives.
Mm-hmm. And the program seems like it's, you know, there is actually a big commitment here for these service organisations to get involved and try to roll this out. What were the main barriers that came out for those organisations when they were trying to, you know, implement this? And, you know, have those barriers been addressed in some way as it's been sort of rolled out into standard practice?
Yeah, yes and no. So, you know, barriers are, as they often are, around resourcing and funding for people's time to be spent on something new, and whether organisations had that perception of whether this was part of their role or not. Because we really did work with what you would call social service organisations as well. So some of them were homelessness services, you know, supported accommodation. Some of them were financial aid services, and that was the clever part of what Cancer Council did in reframing smoking as a social justice issue. And I think that really helped to reframe it in the minds of the organisational leaders, to really understand that smoking has an impact on the social situation that their clients find themselves in. Whether or not all the staff on the ground felt that way as well continued to be a challenge, and so that was part of the intervention was, when I had the slide with the various components of organisational change, and the first component is getting organisational support. So yes, the first step was very much getting that leadership on board, but then we spent a lot of time visiting individual services, going to staff meetings, answering questions, really developing close relationships with the staff in the services. And when you do it as a partnership in that way, they start to see that actually this is, something that's important for me. And now it's tackling tobacco is so well known amongst the sector, the NGO sector, that sites go to the Cancer Council for support to do this. So the Cancer Council don't need to do that active recruitment anymore. They have this program. It's up on the website, and services go to them and say, yep, we want to sign up now.
That's excellent. Are you aware of any programs or trials in youth service settings? It's one of the questions we have here.
Yeah, there is. I haven't been involved in those, but I'm sure that if you look up the website, there might be information there about youth services. I know the Cancer Council was working with, very early on, like years ago, was working with some of the peak bodies in child and family services and other youth services. So the answer is yes. I haven't been involved in those types of services, but there is some work happening in that area. Yeah.
And can you tell us more about adherence strategies for organisations with existing smoke-free policies, or recommend any resources that we can use to improve staff adherence?
Yeah, look, that's really hard. And a lot of it happened through the staff training that Tracy was delivering as well with tackling tobacco. We recommended things like don't have an ashtray right in front of the building, for example. So if the policy, as I recall, in New South Wales anyway, like the policy might have been a certain number of metres, away from the building had to be smoke-free as well, but a lot of clients would gather near the door to have their smoke so they could easily duck in and out. And there was some, I suppose you'd call them smoking enabling tools. So, just sort of getting rid of those, making it a little bit harder to have any sort of spaces near that building. So it's a challenge because if there was a relaxed approach to the policy, clients would react when they notice that where they usually could smoke was no longer allowed or permissible. And And so training the staff up in how to have those difficult conversations was really important. But staff smoking was sometimes an issue as well. And some of the clients would say to us, oh, but I can see so-and-so going behind the building and he has a smoke. And so really offering as much support as we could to staff to help them quit if they, you know, if they were interested to. And some services decided to make not smoking a workplace occupational health and safety issue. So then it became a fine. If you want to smoke at home, you go home and you smoke, but while you're at work, you can't smoke. So there was a range. It wasn't easy, and it was, you know, done on a service by service basis in terms of working together with them on what adherence strategy might work best.
And is there ongoing review of implementation in these settings?
The Cancer Council continues to collect data, and they often, I actually haven't checked recently, I don't know about their last annual report, but they had been reporting implementation data in annual reports for a number of years. So I certainly know that there's data from, say, around 2015, 16, 17, 18 on implementation of tackling tobacco and how many sites are rolling it out. There was some level of, when they provide NRT grants, there's some level of expectation that the services would provide some data to the Cancer Council on, you know, how much NRT was provided, who took it, and so on. So there is data now that it's in that you know, stage of rolling out in the community. It's that is done by the Cancer Councils. And I know that here in South Australia, the Cancer Council SA has got an evaluation officer with the rollout here in SA. That person will, you know, collect some data on how the implementation here happens.
Given the huge effort required for community trials and the weak effects, can you comment on whether this is due to poor implementation or contamination into controls, or represents a fundamental flaw to this way of evaluating the effectiveness of organisational level interventions?
Yeah, so that's a really big question about whether trials are worth it or not. And I would say yes, they are, because this isn't about general population. This is about groups in society who are often left out of that big data set evaluation and, you know, sort of data analysis and policy development. So it is resource intensive, it is expensive, it's time consuming, but if we don't work with communities and people more closely in communities, we are going to leave people behind, as we have been doing in tobacco control for many years. So I think we need both. I think that we need, you know, those population-wide big policy initiatives. But in order not to leave people behind, we need to work at that community level with human beings, with people, and with health services and community, other community services, social services, to ensure equity.
And maybe also like making sure that there are those intermediate measures that are captured, right? So that, you know, given how long it may take people to quit drinking.
That's right. And I think process measures are really important in trials. Again, you know, it's one of those things that we need to write into our grant application so that we really understand, you know,
whether it's working.
What is it exactly that worked or didn't work in that sort of situation? And it was like, you know, your initial comment about that qualitative data and talking to staff. And I've just recently been talking to one of our Brisbane sites from the TNT trial, and, you know, they just happened to mention to one of the directors of that Brisbane site, just happened to mention that as a result of involvement in that trial, they put a dedicated telephone in their service so that clients can, anytime they want, call the quit line. And, you know, like, that's a great outcome. You know, the fact that people in health services didn't have access to quitline is a problem. And unless you do trials like this, you're not going to know that. And that change wouldn't have happened unless the trial happened. So,
yeah, multiple benefits there, isn't it? Yeah. And how was the smoke-free status identified? Did the client self-report, or did they use smokealizers in the services?
Yeah, so we gave services smokealizers, and, you know, to use however they wanted to use them. Often they're used as motivational tools to help people quit. But self-report in a lot of cases, in that history taking, where a lot of, you know, things might be recorded. We just ensured that smoking status was one of them, and then, you know, the other fields grew from that as well in terms of what support that we're getting as well.
Okay, we've got thanks for the great presentation. And can you tell us how you train the staff who smoke? It sounds a bit hard to persuade people who smoke to help their clients to be involved in the program.
Yeah. Look, this was a real eye-opener for me, and this is why it's so important to get in there, to get into the community and talk to people and see what's happening. Because when we started offering the staff training, say in the TNT trial, they're drug and alcohol counsellors. Right, they're drug and alcohol workers, and so you would think that they're experts in addiction and dependency and, you know, treatments and so on. And what we found, and, you know, Tracy noticed this as well, was when she was presenting the data on the harmful effects of smoking on, you know, the body, on health outcomes, staff didn't know that, right? And so you would hear this, oh, right, okay.
Yeah, so it's also an intervention for the staff, right?
Yes, that's right. And so those of us like you and I who work in this field, we think everybody knows now that tobacco smoking is harmful for you, but there are still people who don't actually know how harmful it is for you. So that staff training was invaluable. It didn't convert every staff member, so that's why, you know, as I mentioned earlier, some services decided to implement policies, you know, that became workplace policies, occupational health and safety and so on, where it became a professional, part of their professional role not to smoke at that site, and part of their professional role was also to provide smoking cessation support to their clients who smoked.
And so this is a related question. Is there any measurement on impact to outcomes based on prevalence of staff who smoke?
I don't know whether there is. The prevalence of staff who smoke was fairly consistent. So we found that the rate of staff smoking was anywhere around from 20 to 25% of staff at sites were themselves smoking. And that's higher than the general population average. I don't know whether that's changed now because, you know, hopefully it's changing. But it was fairly consistent. So we didn't really enter that into any model, like proportion of staff smoking. We didn't enter into any modelling to look at whether there were any differences because they were very similar across the board.
And final question, if we can sneak it in, close to the hour. Competing priorities is always a challenge. How do you keep smoking as an ongoing priority?
Yeah, and this is why. So is that about in these settings or generally?
I think in health services, you know, when there's the competing issues that the service is dealing with.
Yeah, so this is why the early groundwork that was done with tackling tobacco by the Cancer Council predominantly was so important. It made my job easier, but there was a lot of workshops run. There was a lot of meetings and partnership and relationship development that went on across the sectors and the Cancer Council in really highlighting the impact of tobacco smoking on these groups. And, you know, sites may say they don't have somewhere to live tonight. Okay, so my priority is to find that family a house tonight. And you absolutely respect that. And, you know, they do that. And this is something then that once the family settled into their home, that they can start working on the smoking element of it, because you highlight that smoking will affect their ability to get a rental. It'll affect their ability to get a job. It'll affect their health and ability to earn an income. So linking all those priorities back to smoking really helped in that sense. But, you know, honestly, I can't speak highly enough of the Cancer Council and all the leadership and the commitment that they showed to this.
Great. So I'd just like to thank Professor Bonevski again for just an excellent presentation and for making the time today to tell us about this excellent program that's been run. Thanks very much, everyone.